Morning, everyone.
Morning, Dr.
Morning.
Rao.
Morning.
It is 8 o'clock.
Yeah, time to start, guys.
Good morning. This is Shannon Switkowski. I'm the clinic coordinator for cardio echo hypertension, and we are at week 9. Thank you for coming. We're going to introduce everyone here at the Cardio Hub, and Dr. Rao is joining us via Zoom. So I'm Shannon Switkowski again.
I'm Rick Carnacci. I'm web content producer for the cardio program.
Jesse Lewis, program manager at CASE.
I'm Luke Laffin. I'm a preventive cardiologist. I'll be presenting today.
Dr. Rao.
Just a few reminders from Shannon that were on the previous screen. Please chat your name into the chat box if you haven't already done so. And if you have any technical problems, those are the numbers to call. And these are our routine disclosure statements. Most significantly, Dr. Laffin is a member of the Hypertension Committee for the CALM-2 trial, and Saran and Adam, I believe, are on this morning as well, although Adam has lost his voice, I'm told, so may be able to chat some responses in response to our case. I'm very pleased Dr. Laffin is able to join us. He's a preventive cardiologist from Cleveland Clinic, and he's going to discuss an integrated approach to cardiovascular risk management, which as a pediatric cardiovascular risk researcher, I know is very important. It makes no sense to tackle someone's lipids without their hypertension or without their
Very true.
So Luke, I'm going to turn things over to you.
Great. All right. Thanks very much. And thank you very much for having me speak today. It's a pleasure. And as was discussed, I'm going to talk about an integrated approach to cardiovascular risk management, and I'm a preventive cardiologist. So the objectives that I was asked to speak about today are as follows. Really in patients with hypertension, to talk about the additional impact of risk factors such as diabetes and tobacco on overall cardiovascular risk. And then finally, I was asked to, the last couple slides, talk about the new aspirin recommendations in primary prevention. So let's start with number 1. Let's talk about these additional impact of other risk factors on overall cardiovascular risk. So I really don't have to tell this group that all of these risk factors go hand in hand. They come together. Hypertension comes with diabetes, comes with smoking. We could overlay obesity on this map as well. This is specifically taken from the REGARD study. And although we're not in the epicenter here in Ohio, we're not that far from the epicenter. So it's just important to recognize that and understand that, which most of us already do. In the most recent 2017 ACC-AHA hypertension guidelines, they outlined very clearly that there's cardiovascular disease risk factors that are quite common in patients with hypertension, and there's modifiable and fixed risk factors, or at least relatively fixed risk factors. On the top of that, I mean, we see the cigarette smoking, we see diabetes as being really the major ones, but we also talk about dyslipidemia, obesity, physical inactivity, etc. So when we talk about this first objective, I think the most important thing really is to hone down on this idea about overall cardiovascular risk, because really this assessment and defining that is what's vitally important to think about when you're seeing that patient in front of you in clinic. And we can do this in a couple different ways. We can do it qualitatively, we can do it quantitatively. I first like to show this qualitative slide more than anything else, and actually show this to my patients in clinic about how we think about cardiovascular risk throughout one's lifetime. So if you look on the y-axis, we see that's the risk of a cardiac event. And we never want to reach that clinical event horizon where we have an acute plaque rupture. That's represented. X-axis, we have increasing age. And then the different red lines, green lines, blue lines are risk trajectories more than anything else. So a lot of patients that we'll see, particularly in the prevention clinic at Cleveland Clinic, are on that red trajectory. So early aggressive cardiovascular disease. The whole goal with everything that we talk about and what you've surely been talking about over the past number of weeks is shifting individuals from that red aggressive risk trajectory to the green trajectory, which is optimal risk factor status. There's certain And so that's really what the goal is more than anything else. Now this slide says add statins, but there's much more to it than that. You'll notice a couple things. One, the green trajectory, the risk is still going up as we age, and we all know that age is the greatest risk factor for cardiovascular disease. And there's other non-modifiable risk factors, such as sex, such as your genetic makeup, and of course age, like I mentioned before. All right, if we can go to the next slide there, great. Now that's qualitatively. When we talk about quantitative cardiovascular risk assessment, not only should we quantify cardiovascular risk for ourselves in the sense that we shouldn't just use our clinical gestalt when we're seeing patients. We need to do it in a quantitative manner and let our patients know about it. Many of us are familiar with the ACC-AHA pooled cohort equation. That's really been the push over the last 5 to 6 years with the release of the 2013 lipid guideline update. But what I would say is that it's less important which risk calculator you choose rather than the fact that you should choose a risk calculator and just use it. That's the most important thing. Can we go to the next slide? So there's specific calculators to different regions. Of course, the United States, the most commonly used nowadays is the pooled cohort equation, that ASCVD risk calculator. Some United States practitioners also like to use the Reynolds risk equation, which takes into account CRP and family history. And then you can see the other constituencies there and what they tend to use from a cardiovascular risk perspective and how to ultimately predict cardiovascular risk in the future. Now, this is a slide taken directly from the most recent primary prevention guidelines, which now are about a month old. They were presented at American College of Cardiology scientific sessions. And it supports this idea that it's a class 1 recommendation that we need to assess cardiovascular risk on a routine basis. This is particularly true of those individuals in the 40 to 75 year of age range. And they recommend using the pooled cohort equation for this to calculate a 10-year cardiovascular risk. They also put in as a 2A recommendation that for adults under 40, it's reasonable to assess these risk factors as well. And we should be doing that really in the 4 to 6 year range, so about every 5 years. Next slide, please. So let's just take a step back here, because I think this is also an important point to bring up, is that when we're talking about an integrated approach to cardiovascular risk management, the most important thing that I always like to say is that elevated blood pressure and elevated blood cholesterol are not like pregnancy. They're not a binary proposition, okay? And if we can click the next slide. They are continuously related to cardiovascular risk. And we all know this intuitively, and it can be difficult, especially when we're clicking boxes and putting in ICD-10 diagnoses to say hypertension or not. But clearly we know the patient with a blood pressure of 160, 170 is much different than the patient with a blood pressure of 141, 142. And that's similar to blood cholesterol as well. We see that continuous relation. So although defining a threshold for hypertension is important, particularly from an epidemiological perspective and somewhat from a just tracking things perspective, I think it's also important to think about hypertension as the blood pressure level above which there would be substantial benefits from lowering it. We know that this logic has already been applied to the lipid guidelines, and we're not really using, except in very high LDL cases, we're not really using strict cutoffs to define hyperlipidemia, but it's really more assessing cardiovascular risk on a continuous scale. The best example of how we actually can integrate all these risk factor managements and think about how they each increase cardiovascular risk comes from a paper in 2005 in The Lancet. What we're looking at here is they essentially have a reference patient who's a 50-year-old woman. Total cholesterol is 155 milligrams per deciliter. HDL is 62. So relatively healthy. She's a non-smoker, non-diabetic. And if her blood pressure was 110 millimeters of mercury systolic, she would be at the very bottom left-hand corner of this with the blue bar in that reference. And we can see her 5-year cardiovascular disease risk would be much less than 1%. Subsequently, the different colored bars next to her are at different levels of systolic blood pressure, increasing by increments of 10 millimeters of mercury. So it's 120, 130, 140, 150, all the way up to 180. And we can see that if your blood pressure is 180, yet you're a 50-year-old woman whose total cholesterol is controlled and HDL is fine, your risk, because of that elevated blood pressure, and as blood pressure increases, is going to be more than the one with blood pressure that's controlled. Now, for example, let's go to the next combination of blood pressures. Oh, let's go back a slide. So if we look at the total cholesterol, so let's say we change her total cholesterol, it's not 155, it's actually 7 millimoles per liter, which if you don't know, that's around 270 milligrams per deciliter. Clearly, we're going to have an increased cardiovascular risk there. Now, if we add on top of that smoking, we'll see another subsequent increase in cardiovascular risk. Add on low HDL, which is a phenotype that we'll often see. We just changed the fact if it's not a woman, we change it to a man, that risk is going to be increased. We add on diabetes, exponential increase in risk as well. Finally, what if we just make them 10 years older? Again, exponential increase in cardiovascular risk. So something to think about, that all of these work, unfortunately we see them oftentimes together, but they all increase cardiovascular risk together. All right, next slide. This is looking at it a little bit a different way, looking at again, a healthy 50-year-old woman with a systolic blood pressure of 110 and relatively normal or elevated HDL, so healthy. And these are different levels of total cholesterol, again, represented by the different colored bars. Now, if we add systolic blood pressure that's uncontrolled, smoking, low HDL, male, diabetes, 60 years old, we see a similar response, increased cardiovascular risk that's significant over 5 years. So just one way to picture that. Next slide. They've tried to even up, like that's this slide, 2000 doesn't seem that long ago, but I guess it was 20 years ago now almost, looking at the Framingham data and creating nomograms and scoring systems to really predict, well, what are different 5, 10, and 2-year probabilities of cardiovascular disease. So this is one way that we can quantify, or at least that it's been quantified in the past, get different points for things like age, total cholesterol and HDL combination, the presence of diabetes, presence of cigarette smoking, the blood pressure level at which, if it's treated or untreated. And then if we add all those numbers up, we can get a 2-year probability. And you can see those are really synergistic more than anything else. The presence of diabetes with other risk factors, you're gonna have a much higher likelihood of, or probability of a cardiovascular event over 2 years. Next slide, please. Similarly, we can do this for women as well, and talking about those that are pre and postmenopausal. So similar idea behind that. Now, that's a little bit less contemporary. And so if we go to the next slide, we can talk about a more contemporary example with the pooled cohort equation and the ASCVD 10-year risk calculator. And I'm sure many of you are familiar with this, and hopefully you're using it routinely in your primary prevention patients, given the level of evidence, or the guidelines at least, stated. So this is an example from a recent patient that I saw in clinic. 54-year-old gentleman, he's white, he's has hypertension. This was the first time I saw him, not on any blood pressure medication. His sitting blood pressure was 144/73 millimeters of mercury. His total cholesterol was 205. His HDL was sort of borderline at 41 milligrams per deciliter, and LDL was 145. He's non-smoker, non-diabetic, not taking any other statin or aspirin. If we plug his numbers in, and I did it in front of him, he's at about a 7.5% 10-year risk of cardiovascular disease. Of course, we know that optimal risk factor at this age, if we control everything, it'd be about 3.2%. So his risk is doubled. Now, let's say that he actually has the presence of diabetes. So next slide. If he does have the presence of diabetes, this is just to illustrate the effect that diabetes, smoking, et cetera, will have on that cardiovascular risk and that assessment of risk. So it essentially doubles it, or close to doubles it, to 14.3%. Let's say we take away diabetes, but make him a smoker. He decided to take up smoking again. All right, can we advance it, please? Again, similar increase in cardiovascular risk from that about 7% to in the 14 to 15% range. And then what if he's both? He's diabetic and a smoker. then we see a significantly increased risk, over 26%. So that clearly places him in a high risk category for cardiovascular events. So it's important to use this and be illustrative to individuals in clinic that all these risk factors come together and play a role. And I think that's really important. Next slide. When we talk specifically about smoking, the primary prevention guidelines, of course, allude to it, and this is the number is 4 on that list there in the 4th row. In adults who use tobacco, abstinence, of course, is recommended to reduce that overall cardiovascular risk. All right, next slide. Let's skip this slide for now. I don't think that's as important. Okay, so objective number 2 that I was asked to speak about was discuss the current recommendations for screening for lipid disorders and for diabetes. Now, the primary prevention guidelines, I think I would move away from saying just screening for lipid disorders. It's more of a terminology perspective. We don't do that so much anymore. We assess overall cardiovascular risk, and lipids play a role in that. There's no question. So this is the same table that I showed you earlier in terms of who we should be screening and when we should be screening them. So I'm going to repeat it because it's that important. 40 to 75-year-old individuals, we should be routinely assessing their cardiovascular risk, usually in the 1 to 3 year range. And we do that via some mechanism. They recommend the pooled cohort equation. And then younger individuals, less frequently, but definitely it's reasonable to assess it. One question that I'll often get, and I think is important to talk about briefly, is there any role for advanced lipid testing or additional lipid testing? And this was addressed in the most recent lipid guidelines or cardiovascular risk guidelines published at the end of 2018. And so if we can go to that slide there, perfect. And this is talking about primary prevention. And the one thing to remember, if additional lipid markers played a significant role in discriminating risk between groups, they probably would have been incorporated, or they would have been incorporated into the guidelines in a codified fashion and added to the risk calculator. That being said, they do help us evaluate risk a little bit more granularly, but it's not going to make a big difference either way. And the way that they addressed those in the most recent lipid guidelines was talking about ASCVD risk enhancers. So the presence of certain risk factors that, although they may not greatly shift which risk category you're in, they do play a role, especially in individualized decision-making about who we should be more or less aggressive in terms of cholesterol management, et cetera. So an example of that is something like lipoprotein A. We know that we don't have anything to bring it down in people with elevated lipoprotein A, or at least anything FDA approved for lowering those levels. However, if an individual has a more elevated risk or a more elevated level, we probably want to be more aggressive with them. Similarly, we can say that about C-reactive protein, persistently elevated triglycerides, ApoB. I think the interesting part is this triglyceride issue. I'm sure you've heard lots about it in terms of the REDUCE-IT trial and the introduction of Vascepa as something that not only decreases triglycerides, but also decreases cardiovascular events. So that's something we'll probably see more about as we move forward. So as an example, at the prevention clinic, at the Cleveland Clinic, we'll rarely check any of those advanced lipid panels. We'll oftentimes check maybe a lipoprotein A, potentially a CRP, but any of the NMR lipid panels, they don't really provide enough data for us to actually change what we're going to do. All right, next slide. Okay, so next is talking about screening and testing for prediabetes and type 2 diabetes in asymptomatic adults. And what I wanted to really focus on there is the most recent standards of care released by the American Diabetes Association. So they were, if you are not familiar with them, they update their guidelines on really a continuous fashion every year. And they're typically published in Diabetes Care. And so this is the ones that they recently released. Number 1 on the screen there, talking about screening for prediabetes and type 2 diabetes should be done with an informal assessment of risk factors or a validated tool. And so that's what we can see. And they have validated tools on their website, the ADA's website. When we talk about 2, I have that highlighted because I think that's important as well. Testing for prediabetes and type 2 diabetes in asymptomatic individuals should be considered in those patients that are overweight. And remember, Asian Americans, we tend to give them a lower BMI cutoff for that, and then have additional risk factors. And what are those additional risk factors? You click forward. And this is what's laid straight out there in the guidelines. So anybody with a first-degree relative with diabetes, individuals of a high risk ethnicity or race, and those are listed there. So African American, Latino, Native American, Asian American, Pacific Islander. Of course, if anyone has a history of cardiovascular disease, history of hypertension, low HDL or elevated triglycerides, if they're physically inactive, which unfortunately is a wide variety, many of our patients, and then women with PCOS is also one of those extra risk factors that we should probably be more aggressive about testing those patients for diabetes and looking at that. All right, next slide. Testing should begin at the age of 45 years, and if someone has normal testing, we should repeat it at a minimum of 3-year intervals. We can even space that out a little bit if necessary. Okay, next slide. All right, let's talk about the thresholds for pharmacological blood pressure treatment and treatment goals for patients with type 2 diabetes. So as many of you know and have seen over the past 20 years, it's really a pendulum that seems to be going back and forth in terms of what's our goal in diabetic individuals. 140/90, 130/80. Right now we're at 130/80. I wouldn't be surprised in 5 to 10 years if someone says it's lower, someone says it's higher, but this is where we are at this point. Many of you are familiar with the ACC-AHA 2017 guidelines, and it's a class 1 recommendation that in patients with diabetes and hypertension, drug treatment should be initiated at a blood pressure of 130/80 and treatment goal of less than that level as well. Next slide. Those same American Diabetes standards of care, American Diabetes Association standards of care, excuse me, address blood pressure in less of a, I guess, heavy-handed fashion and have a little bit more of a paint a little bit with a finer brush with this. So number one, of course, as all guidelines are apt to say today, we want to take an individualized shared decision-making process that addresses cardiovascular risk and the potential risks associated with antihypertensive medications. Especially we have to be cognizant of that in patients with kidney disease as well. When they talk about who specifically we should be aggressive about blood pressure targets, what they define as patients we should be more aggressive with are those individuals with existing atherosclerotic cardiovascular disease or a 10-year ASCVD risk of greater than 15%. That's not a typo and a change in font there. That's specifically made bigger because you may notice that's different from the ACC-AHA guidelines that use really a 10% cutoff for ASCVD risk when we're talking about increased intensity of blood pressure lowering. And this is, I don't know the correct answer, whether we should use 10 or 15%. The logic behind 15% is those patients enrolled in the SPRINT blood pressure trial, they were thought to have they had to have a 15% risk of an atherosclerotic cardiovascular event over 10 years. So that's where that 15% number comes from. For those individuals at less than 15%, a 10-year ASCVD risk, we want to treat them to a blood pressure target of 140/90 based on the diabetes ADA guidelines. Then the big question that many of you are probably asking and asked when these most recent blood pressure guidelines came out was, well, really, are these changes in accordance with the available data? So we know that the newer blood pressure thresholds were driven by data from SPRINT. And that was a study in elevated cardiovascular risk, but non-diabetic patients of office blood pressure of 120, targeting a systolic blood pressure of 120 versus 140. And we know that was a quote unquote positive trial in that there was, the primary endpoint was decreased in those individuals with intensive blood pressure therapy. But this stands in contrast to the earlier trial, which was the ACCORD blood pressure trial, which looked at same thresholds for blood pressure treatment, or targets, but in patients at elevated cardiovascular risk with diabetes. As you may remember, this was a quote unquote negative trial if we just look at the abstract, and it didn't show any difference in terms of major adverse cardiovascular events. However, There's 4 important points that we need to remember to think about as we try and rectify this in our brain about, well, why is this and why was there this difference? Remember, SPRINT enrolled twice the number of participants as the ACCORD blood pressure trial. ACCORD was a 2x2 factorial trial. Not only did they look at blood pressure, they looked at different methods of lipid lowering, and they looked at intensive versus standard glycemia therapy. So ACCORD itself in the blood pressure arm had about 4,700 patients enrolled. SPRINT had over 9,000. SPRINT captured more cardiovascular events in its primary endpoint compared to ACCORD. The primary endpoint in SPRINT also included acute decompensated heart failure. And that was not the case in ACCORD. ACCORD had that as a secondary endpoint. Of note, heart failure accounted for almost 1/3 of all the events observed in SPRINTs and really drove the primary endpoint more than anything else. So that's important to remember. And when we think about it, we know that heart failure is very sensitive to blood pressure reductions. It's a sensitive cardiovascular event, whereas MI is a little bit less so in that setting. So just some important points to remember. Now, you don't have to take my word for it. We can also look at some post hoc analyses. And there's been a variety of these, trying to look at that ACCORD population and say, well, why was there no demonstrated difference in cardiovascular events? The most widely quoted is this study published in 2014 in Diabetes Care. And essentially what it was it looked at the ACCORD data and it broke it down a little bit more granularly and showed that intensive blood pressure or intensive glycemia treatment alone improved major cardiovascular disease outcomes by 26% compared with the standard combined treatment. However, when we combine those two, there was no additional benefit. So keep that in the back of your mind, because next slide, there was also follow-up to the ACCORD blood pressure trial. And unfortunately, this really, in a specific way, hasn't been published. It was talked about as a late breaker at the American Heart Association Scientific Sessions in 2015, but this accordion study was a follow-along study after the end of ACCORD. So almost 90% of those ACCORD blood pressure participants consented to being followed for up to 60 months following the trial. The major take-home point was, well, after the 5 years in the trial, there was no reduction in the rate of cardiovascular events over a median follow-up of almost 9 years. So they allowed people to go back to the more standard blood pressure at that point. They weren't intervened upon anymore. However, it showed that there's no legacy effect from decreasing blood pressure over that 5-year period. However, I think probably the most important thing or the most interesting thing to note is that they noted a significant interaction in the intense glucose therapy group with evidence of benefit for intensive blood pressure lowering in participants randomized to a standard blood glucose therapy. And if we can click the next slide, we can show that, and that's circled on there. So that suggests that if we're treating standard glycemia, which most of us are at this point, then we probably will see a decrease in cardiovascular events. Other groups have tried to look at, well, what if we parse down that ACCORD blood pressure population and look at those patients that would have been eligible for SPRINT, excluding this diabetes component to it. So Buckley's group did it. Again, this was published at the end of 2017 in Diabetes Care. And they looked at this ACCORD blood pressure population, which again, as I said, was about 4,700 patients. And they parsed it down to those patients that would have been eligible for SPRINT based on all the risk factors other than diabetes. And what they showed, if you can go to the next slide, was that irrespective of what composite primary endpoint we used, so panel A is the SPRINT composite endpoint that included acute decompensated heart failure. Composite endpoint B is the ACCORD primary endpoint, which did not include acute decompensated heart failure. We see that in that SPRINT eligible participants of ACCORD, intensive blood pressure control resulted in less cardiovascular events, less risk of future disease. So all of this tends to, it's all shading one way or another to showing that intensive blood pressure control is probably better in those patients with diabetes. Next slide. what's the bottom line and take home of that I would like to share with you today? Well, SPRINT provides the most contemporary RCT data for blood pressure treatment targets. It demonstrates a clear benefit for more aggressive blood pressure lowering in the population that it studied. And although it did not enroll patients with diabetes, its findings, I would argue, should be applied to patients with an elevated risk of cardiovascular disease, and that does include patients with diabetes. How you want to define elevated cardiovascular disease otherwise, be it 10%, be it 15%, I'll leave that to you. The guidelines are varying on that, but I think it's important to understand. SPRINT, as I mentioned, it used a 15% ASCVD 10-year risk to get enrolled. All right. Finally, let's talk about the new aspirin primary prevention guidelines quickly. So these primary prevention guidelines, many of us have probably looked at them and are familiar with them at this point, but let's talk about number 3 at the bottom there first. Click forward. Next. Or actually go back one, sorry. So this is low-dose aspirin should not be administered to anyone of any age who are at increased risk of bleeding. Makes sense, but they have to codify it in here. What makes us at increased risk of bleeding? We all know these scenarios. GI bleeding, CKD, coagulopathy, low platelets, other medications that could increase risk of cardiovascular disease. And then that age over 70 is also important. And that's why now it's a change in the recommendations that we should not be prescribing low-dose aspirin for primary prevention in adults over 70. And the reason for that is that prophylactic aspirin in that age group is potentially harmful given the higher risk of bleeding. And as it's stated clearly in the guidelines, it's difficult to justify routine use. Now, the one thing that we're getting a lot of calls about, and I'm sure you are too, this is primary prevention. This is not secondary prevention. Secondary prevention, there still is clearly a role for aspirin therapy in this group. Then the downgraded recommendation was low-dose aspirin for primary prevention among select adults between 40 and 70 years of age. This is now only a 2B recommendation, so not particularly strong evidence, and I'll explain why that is in a second. So it says in select adults. Many of you are probably familiar with post-hoc studies of older trials suggesting that the benefit-risk ratio of prophylactic aspirin generally becomes favorable at about the 10% estimated ASCVD risk. This is out, and then this is because of a couple factors. One, the relative benefits of aspirin in preventing MI and stroke have been less evident in more contemporary and recent clinical trials. Also, we know that in recent trials, the estimated ASCVD risk has generally exceeded the actual risk observed during follow-up. All right. So where does that leave us? Well, we really need to consider the totality of the available evidence for ASCVD risk when we're thinking about aspirin or not in that 40 to 70-year-old age range. So thinking about those risk-enhancing factors is important. Does someone have a really strong or premature family history of early atherosclerotic cardiovascular disease? As you know, we define that in men, first-degree relatives that are men under the age of 55 and first-degree relatives that are women under the age of 65. Keep going back one. And then we look at also things like, we can look at other biomarkers such as significant elevations in coronary calcium or those other non-traditional risk markers like CRP, like lipoprotein A, like ApoB. And we have to tailor decisions about prophylactic aspirin to patient and clinician preferences. So that's all I got for you. Thank you very much. All right, questions?
Okay, thank you, Dr. Laffin. That was absolutely terrific. Great comprehensive review. I remember your name from the University of Chicago a couple of years ago.
Yeah, that's right.
Program. That's right. So anyway, there's a couple of questions. I wanted to ask a couple of questions, and then Dr. Aurora and Christy O'Day have some questions as well, which I'll read out. We do have a little extra time because we only have one case presentation. One question, did the ACC look at aspirin, the new aspirin proton pump inhibitor product called Yosprala, which has been around for a couple of years? It's basically aspirin wrapped in a proton pump inhibitor that diminishes the risk of bleeding. Any comments about that? Or are you?
Not any in-depth comments, to be perfectly honest with you. I think it definitely could be helpful in that setting. We know that PPIs are not benign necessarily either. So I'm not as familiar with that combination product. I don't.
Yeah, it hasn't sold well. It hasn't caught on, but it's something that's been around. A couple of questions. One from Dr. Aurora that I am curious about as well. Do you have any comments about the use of statins in patients over the age of 75?
Yeah, that's a great question.
The LDL level and the high intensity statins almost always seem to result in side effects. So.
Yeah, and that's a question that we deal with all the time. These people coming in, and unfortunately, we don't really have a lot of data to help guide us in this older population. And that really gets us to this idea of individualized risk management more than anything else. Because the 75-year-old, when we were studying in the 90s, is very different from the 75-year-old that we see now in almost 2020 here. If you think, or if we see a patient that is healthy, active, not many comorbidities, cardiovascular or otherwise, I tend to be more aggressive with starting statin therapy because we see, I mean, it's over short periods of time that we can see benefit with statins because their absolute risk is so high, even if we decrease, because their absolute risk is so high. So I tend to start with a low intensity statin, and usually that will come in the, well, actually not a low intensity. Let me take that back. I start with a low dose of a moderate intensity statin, particularly if I think they're going to have side effects. So typically 5 milligrams of rosuvastatin is what I will go to. And we don't even start once a day. Oftentimes we'll start a few times a week, see if they're doing okay with it. And then we can increase moving forward.
Okay, thank you. There's one final question from Christy O'Day. And this deals with chronic kidney disease and the contraindication for aspirin treatment. What stage of CKD or creatinine would you recommend as a threshold to?
Yes. So my understanding of the CKD literature is that, I mean, your bleeding risk is increased at any stage of stage 3 and forward. However, I wouldn't hesitate to use it in patients with stage 3A or 3B. Stage 4, we have to think about a little bit more carefully. And of course, stage 5 or end stage renal, at significantly higher risk of of bleeding. And then I would tend to back off.
Okay, terrific. Thank you, Luke.
We are still advertising that registration is open for our cardio conference on May 17th in Columbus. So please visit our website to register. If we get enough of our pilot echo cohort, we hope to have a meetup there if you register. So I'd love to meet you all in person. If you'd like to take the trek to Columbus, I'd love to meet you. And there will be an echo workshop. So if you're interested in attending and telling other people what it's like, we'd love for your first, in-person feedback as well. And then finally, there are CME credits available for today. I do want to start letting you know that as soon as the series is over on May 2nd, we will begin sending out exit surveys, and there will also be a CME survey to be able to obtain your CME credits for attending. And so there will be more information to follow, but I just wanted to give you all a heads up about that. And then finally, we will hear from Dr. Sharu Kansal from Case Western Reserve University and University Hospitals on the diagnosis and evaluation of secondary hypertension. And that's next week. So we hope to see you then. Have a great week. Bye.